Hey Mo,
Hey, Ricky.
how are you?
Magical. I'm magical. I'm waiting for spring. I'm excited about it. We're having in Pennsylvania the Black Health, the Pennsylvania Black Health Expo, and all week long we're doing talks about health and wellness. And this is a subject today that we don't get to talk about very much. And this is just for the breasties. So the doctor is in. How you doing this Wednesday?
The doctor is in. The doctor is in. I'm waiting for spring to come too. I keep getting disappointed. Mo, in my next life, I want to be a weather person. You can wear cute clothes. You could be on TV every day, and you can be wrong on tape every day. These weather people they are horrible, right? Every
Blame it
day.
on Mother Nature. You can just blame it on God. Like, well,
I
what are you
know,
gonna
but
do?
like, what do they do every day? They report and they're on tape that it's going to be 70. Well, it's not. It's 51. Okay, it's not 70 degrees today, but whatever. But anyway, we have a great show. I'm so excited to talk about this because it's something that I wish I had had when I had my mastectomy. We have two great guests. One is running out of surgery to get here, Dr. Michael, but we have our lovely, lovely, lovely breastie over here, Stephanie Stevenson, and she's going to talk about her experience. But we're talking about restoring the sensation in your breasts
Yeah.
with a mastectomy. What a
It's
concept.
when you talk about this cold weather, we used to call it nipply weather, right? Like you go
Right.
out and it was cold and your nipples would respond. And when you have a mastectomy, I don't know if the doctors always tell patients that you lose
Mm.
sensation. You lose it from like here all the way down. And
Somebody told me,
some people may regain some of it. Some people get to keep their nipples, some people don't for whatever reasons. And that loss of sensation is huge for your sense of self, for your intimacy, for the cold, for the heat, for all of it. So we definitely want to talk about this today because we're like blowing the roof off this thing today. So Stephanie,
yeah,
how you doing and feeling?
I am doing wonderful. Thank you guys for having me on today.
cool, cool, cool. Yeah. I mean, I never knew anything about this. I mean, and I had no concept of this, but why don't we, so waiting for Dr. Michael to come, who actually does the surgery. He's run out of surgery, but we have a really cool video that kind of explains what this is all about. So why don't we show it while we're waiting? Let me try to share my screen and show this because I think it's a really cool picture of what we're talking about here. And I suck at this.
Yeah.
Nope. Can you see that?
Yes.
And just, and here you go, enlarge it and make sure you share your
A
screen.
breast cancer diagnosis. The list of questions running through your mind feels never ending. How did this happen? Will I be okay? Why me? Your top priority is getting rid of cancer, but there's a long-lasting side effect of mastectomy that likely never crossed your mind. Incisions and stitches heal with time, but numbness and lack of sensation can be permanent, a constant reminder of what you've been through. Numbness occurs because the nerves in your chest are cut during a mastectomy when the breast tissue is removed. This means they can no longer send signals to your brain that help you feel things like temperature or touch. It might not seem like a big deal at the time, but women say they weren't prepared for how numb they would feel or the impact on their day-to-day life. Think about numbness after a dental appointment, the awkwardness and overall discomfort. Now imagine that feeling being permanent and covering a large portion of your chest. You may not be able to feel warm water on your chest in the shower or the pressure of a seatbelt to know if it's too tight or loose. You also may not be able to tell if your chest is injured while cooking or doing physical activity. Most of all, the sense of touch is gone, whether it's being able to feel the embrace of a child or a moment of intimacy with your partner. Advancements in treatment give us hope. With resensation, it can be possible to feel closer to normal, to surrender one less thing to cancer. During breast reconstruction, the nerves that were cut during your mastectomy can be reconnected using processed allograft nerve tissue. Over time, the nerve can regenerate to potentially restore feeling and sensation. Numbness doesn't have to be the standard for the rest of your life. Talk to your doctor and care team about resensation. You can hope for more.
So first of all, wow, because we could tell you, but we could show you better than we can tell you, right? So Stephanie, would you share with us your story from diagnosis and just tell us, how you got here today and where you are today in your treatment and survivorship?
Okay. Well, I have 3 children. After my second child was born, I developed a lump in my breast, and that was back in 2013. And did the ultrasound. They said it was nothing. Back and then time went on back in, and then in 2015, that breast started leaking. And so I was referred to a breast surgeon, and he sent me to do another ultrasound and do another mammogram. And they said, it's nothing. So,
Really? Gosh.
so then in 2019, my breast started leaking again. And I was referred to a different breast surgeon this time. And she was like, I don't care if it's nothing, we're going to take it out, kind of whatever it is. Well, did the mammogram, did the ultrasound. They said, something doesn't look right. So we need you to get a biopsy. So got the biopsy. The doctor who did it, I think it's a radiologist. I can't remember who does the biopsy. He was like, it doesn't really look like it's cancer. I've seen cancer before. It doesn't really look like cancer. Well, lo and behold, like June 5th, I found out it was breast cancer.
How old were you?
38. And so from there, I went and met with my breast surgeon, and we talked about all of my options. And because it was very early, I could have done a lumpectomy or I could have gone with a mastectomy. I chose to get a mastectomy, a single mastectomy. And she referred me to Dr. Marissa Beggy, my plastic surgeon. She said he was a young doctor, very innovative. So she referred me to him. And so on July 16th of 2019 is when I had my mastectomy and my reconstruction, all done within the same surgery. And after that, it was a roller coaster of one oncologist says chemo, one says you don't need chemo. The radiologist says, oh, maybe you should think about it. So I opted not to get chemotherapy or radiation. I just felt that, after listening to all the doctors, I even went to Emory I got second and third opinions. And so.
And what kind of breast cancer do you have? Did you
Yeah.
have, do you know, like, was it?
It was a DCIS.
Okay. Was it
Mhm.
estrogen receptor positive?
Yes.
Okay.
Yes.
Gotcha.
So, so I decided, not to do chemo or radiation. So they got all the cancer July 16th, and I've had a couple of more reconstruction surgeries since then, but everything has been well since then.
What are the other reconstruction surgeries you've had?
So the December of that same year, it was kind of a lift with the other breast, making sure everything was, symmetrical. And then I had another surgery this past December. Just kind of feeling everything, needed more lifting. So
Mhm.
it was a pretty big surgery because we did the deep where they
Ah,
take
so-
the
Oh, you
tissue.
did. Oh, you did.
gotcha. We were gonna
Yes.
ask you if you had
Yeah,
implant-based
yeah,
reconstruction or not.
yeah.
And so,
Yes.
so did they offer you tamoxifen or some estrogen blocker after your surgery?
Listen, I'm having some struggles with it. I am back on tamoxifen for the most part. I took a break from it
Mhm.
for a little while, but I'm trying my best to stick with it. But yes, I'm on tamoxifen.
Well, as an aside, I'll tell you that tamoxifen, if you have to, can be half dose every other day if you absolutely have to. And that the latest studies out of the American Society of Breast Surgeons says that a woman could take a holiday up to almost 3 months if you have to.
Okay.
But just because it's a hard thing for women to stay on those pills. And I know like it's difficult. Your vagina can be dry, you can have hot flash, joint aches, etc. So we can talk about it offline. But for people who are watching who are suffering with that, we'll get to that too, Ricky, on another show. But
Yeah,
we got
that's what I want to talk about. We
yeah,
need to do a show on tamoxifen because so
side
many people
effects.
are struggling with the side effects of
And
tamoxifen. Yeah.
evening
Yes.
primrose oil is going to be a big help for you.
Yeah.
Okay.
1,000 milligrams 3 times a day. Talk to your doctor about it. I'm not giving medical advice. I'm not your doctor. I have to say that. But talk to us
Writing it
about the
down.
decision, but to
Right.
just do a unilateral mastectomy, one, because there is some
Yeah.
decision making that's there. And some women come to see me, they're like, take them both off. And some women are like, you know what, if it ain't broke, don't fix it. And
Mhm.
so how did you arrive at that decision? And do you feel good about it? I'm sure you do, but talk to us about it more.
Yeah.
Well, breast cancer did not run in my family on either side. So I didn't understand why this was happening. And because I didn't feel like I was a high risk, even though I did get breast cancer, I didn't see the need of taking both. And if I got one good one, I'm gonna keep the one good one. So I just decided it wasn't necessary to do both.
So you know that most breast cancer isn't hereditary, right?
Yeah, I mean, yes, I've learned that on, on this journey. But I
And
just,
have you had your first mammogram since your surgery and everything, or
oh
not
yeah,
yet?
I've
Okay.
had a couple.
Okay,
Yeah,
good.
yeah,
Because that's the
yeah.
hardest part. The hardest
Yeah.
part is that
Yeah.
first mammogram
First
after
mammogram.
treatment is over. So yeah, you're rocking and rolling, and that's
You're
beautiful.
rocking it. You're rocking it. You're rocking it.
I'm glad that you went and pursued the symmetry too, because that's the other thing. When women opt for one breast and they don't do the other, a lot of times they end up with something that's sitting up here and a natural breast that's sitting a little bit lower.
Mhm.
And your doctor paid attention to all those things. So talk to us about the conversations with your plastic surgeon.
Yeah. Yeah.
So, to be honest with you, I, when you hear breast cancer, I don't know that I retained anything other than you have breast cancer, you need to have so a lot of what I remember was kind of, this is what we'll do in surgery. We're going to take, this from here. We're going to do this here. He did mention the resensation, but to be honest with you, that was not even a priority at the time for me. It was, let's just get rid of this cancer. And so even though he did mention it, he explained to me what the process was. It just wasn't high on my priority list at that time. It was, let me get through this surgery. Will I have to get chemotherapy? Like those were the things
Yeah.
that were on my mind.
Everything is like wah, wah, wah right after the cancer word. But so did Dr. Michael explain what he was that resensation was an option? Did he just went ahead and sort of assume you wanted it, or did do you remember that at all?
Yeah, I don't think it was like, do you want this or not? I think it was, well, since I'm getting the deep surgery, this is something you can get with it. You get the, nerve grafting with it. And so I don't remember him saying, do you want this or not? I just think
Okay.
I just
Okay.
remember it being part
Right.
of the
Interesting. Okay.
I can
Interesting.
speak to that a little bit, Ricky. And the one thing is, when a woman hears she has cancer, like I'll talk about symmetry. One nipple might be here, one nipple be over here. And I'm like, do you want your nipples to match? How do you feel about your breast? Do you have back pain? All that stuff. And even then they're like, who cares? I have cancer. Like,
Fix
why?
it. Yeah.
Right. And why am I even thinking about this? This is vain. It's not vain. I promise you, it's not vain. And convincing a patient that their breast appearance matters in the scope of everything else that matters more, like life, is a really hard thing to do. But when they do the deep surgery, they have to dissect out certain vessels that are near those nerves. So it's like right there. And so it's an easy thing. I won't say easy, but it's very accessible to do nerve grafting. And when you say to a patient, well, I can help to try to preserve your sensation, would you want that? And they're like, yeah. And you don't go into detail further unless they ask more questions about it. And so I think you're bringing up a really good point that we could do a better job of even having that conversation about what do you feel, how do you feel it, and then what you might feel, afterwards. But it's a good thing to put in the package of your surgery to restore sensation. Like that's the kind of the way it should go almost, right?
Right, because that's the best thing we can do for you. But can we explain the deep surgery to people? Because not everybody knows what that means, right?
Sure.
Yeah. Go
Stephanie,
for it.
would you like to, you
Oh,
want me to
me?
explain it,
Oh.
or I can, or you can, once you start, and then I'll fill in the medical gaps.
So which is the blessing out of all of this, they took all the tissue from my belly after giving birth to 3 children. They took all of that goodness, they took that out, and that is now the tissue that is in my breast. So I did have to have a tummy tuck along with the mastectomy when I got all of that done, but they just took the tissue from my stomach and put it in my breast.
Yes, that is the short answer and the easy version. There are blood vessels that supply the extra, the fat, I'll call it, and excess skin right around that belly button. And the doctors have to go in, and it is a long surgery. It can take 8, 10, 12 hours sometimes. And they find that blood vessel, and it's like an island almost. And there's a little vessel that they elongate, and they pull it out, and then they connect it to the vessel in the chest, the internal mammary. And it's like a one-to-one connection where they connect those 2 blood vessels together, and they sew it using what's called microsurgery. So they connect the 2 vessels so that that fat will live. They put it underneath the skin, and then they close it up. So in terms of how patients feel, it feels like your own breast tissue because it's fat, right? And our breasts are generally fatty. So the happiest patients long-term, when they do like the satisfaction studies, 15, 20 years out, patients are pretty happy with deeps, even though their scars might be bigger, but it feels more natural.
Well, I am 100% happy with it because it feels as natural as it can, as it could. So yeah,
That's awesome. And no more mammograms on that side. No more ultrasounds unless we have to. Hey, there he
Hey,
is.
Dr. Michael.
Hey, Doc, how you doing?
I am doing incredibly well. Thank you so much for your patience.
No worries. You're saving lives over there. That's important, right?
I just finished a resensation case, so the timing is perfect.
Oh, that's so great.
Wow.
Unfortunately, just the OR was running behind. So thank you so much for your patience. Great to see you, Ricky and Stephanie and Dr. Gray. Just so great to see you guys. So
absolutely. It's good to see you. We're just talking about the conversation that we have with patients surrounding sensation and how resensation goes. How do you talk to a patient about it? This is that first meeting, they got cancer, the breast surgeon sent them to you to talk about reconstructive options. How does that conversation sound?
Well, I think the critical component of that is trying to set expectations early on. And we're very excited about the resensation techniques, and I certainly am a believer in their efficacy, but it's also important to establish the fact that best case scenario, we get back to baseline sensation, and sometimes we don't always get there. The hope and the promise of these techniques that we're excited about is that it will hopefully get you closer to your baseline and perhaps get you there faster, particularly in the central mound of the breast, which is historically a frustrating area in terms of regaining sensation. So I'm careful to counsel, patients that you can expect to, over the course of 6, 12, 18 months, slowly regain sensation. That'll typically occur on the periphery of the breast. And then over time, the hope is that you gain some more sensation towards the central aspect of the breast, and specifically the nipple complex if it's a nipple sparing mastectomy.
That's pretty cool. That's pretty cool. So we showed the video so people could kind of get a sense for what you do. And I think one of the interesting things that Stephanie just told us is that you kind of didn't even really give her this as an option. You just kind of did it. You know what I mean? That's part of her deep surgery. Like, let's just do it. So that was like, wow, that's pretty cool. And she, also made the point that, when you hear that C word and you're talking about what you're going to do, everything sounds like wah, wah, as a patient, you don't know what's going on. I know what's going on. And frankly, my doctor didn't give me any indication that I would even lose my sensation. I had no concept for that. So I think that what you're doing is so cool because you're just making life happen and giving them the best care they can to get back what they lost, right? Which is pretty cool, or what they could lose.
Well, I think, some of that, I think, speaks to the fact that this truly, in my opinion, is part of total rehabilitation of the breast. And to me, doing everything you can to preserve sensation is such a critical part of that.
Mm.
And it's so, at this point, so ingrained in my thought process and how I sort of think of these cases and care for patients that I'll be the first to admit, as passionate as I am about it, I probably don't spend enough time discussing that specifically because, again, to me, it's just another part of the case where this is something that we really need to work on in terms of optimizing patient care.
Absolutely. That it is part and parcel with the mastectomy and the reconstruction is a very cool thing, actually, rather than a separate optional thing that you could consider, which, we get that it is a separate part of the surgery and procedure and consent and all those things. But the consideration about your sensation should not be an afterthought. And I think that that's really where we have to go with this technology and with all of what we do to restore a patient's sense of self, because I think as breast surgeons, we don't talk enough about the grieving and the loss. What are you going to lose? So when I start talking to patients about mastectomies, I talk to them also about intimacy and about finding other erogenous zones and about touch and, the importance of that with their partner. And you got cancer and you might not be thinking about it, but when you go home, as we're gearing up for your surgery, I want you to think about what feels good to you and where. Are there other places, your small of your back, your neck, higher up on your chest, that make you feel that make you feel more feminine or more like yourself? Because you may lose this, and you may lose it for a while. You may regain it, you may not. But where are the other places that feel good, that help to redirect that sense of loss? Because you grieve for this, and we don't necessarily let patients know about that grief, right?
Yeah, that was something that was not, I didn't know that I was going to lose sensation. Like I just
Me either.
it never occurred to me that was going to happen. And now that it's 2+ years post and I am intimate with my spouse, it feels good to feel it.
I'm sure it does.
And my husband was like extremely blown away with the look, how it looked. He was like, I can't believe just how great it looks. But he doesn't feel what I feel, and the feeling part, the sensation part of it is important. And because I don't have my nipple, it's a reconstructed nipple, I do see the difference. And to know that, man, I could have no sensation, like absolutely none. And so you notice the difference, you feel the difference. And 2 years out, I'm glad that I have it. 6 months after the surgery, I probably could have cared less about it, but now that life has gone on, I'm glad that I'm able to have sensation and feel it.
Sure.
It's funny because I don't have it. right? I didn't have this option, and I can't describe what it feels like to people. Like when people say, well, what do you mean? What can you feel? I can feel you touching my skin, but I can't really feel anything. You know what I mean? Like it's hard to describe that to people, but that's what it is, like, even actually I was telling the story, I told the story a couple weeks ago, my 4.5-year-old granddaughter, a couple of weeks ago, we were in the shower and she's like, so Debbie, how come you don't have those things on your boobs that baby heart sucks on? Because her baby sister's nursing. And so I explained breast cancer to her, but I said, well, feel this. Doesn't it feel like I have like balloons under my skin? And I'm like, touch my boobs. She's like, yeah, I feel it. And then we felt her mother's boobs and the milk squirted out. But she said, gosh, they do feel really different. But I said, I can't really feel it. You know what I mean? Like it's hard to describe that, So to be able to have this option and have such a natural feeling thing that we deserve as patients is awesome. I think it's awesome. So how do people know about it? Like you were so blessed to have Dr. Michael as your doctor. Is this widely known, Dr. Michael? Like who's doing this stuff? Like, are you doing it in your hospital, Mo? Like,
Well, I would say I have to give credit to my mentors at the University of Pennsylvania, and specifically.
there you go. That's where Mo is.
Yeah, I work with Evan Katzel and Joe Cerletti. So
So Dr. Cerletti. So
I do.
Dr. Cerletti, I have to say, has had more of a profound influence on my life professionally and personally than anybody outside of my parents. And he's somebody that is historically a pioneer in microsurgical breast reconstruction in general. And if you'll entertain me to tell a little bit of my story. So, again, Dr. Cerletti, I was fortunate enough to train under him, and he was my mentor. And so he really pioneered microsurgical breast reconstruction. The original version of that, the tram flap, was described by Dr. Hartram, who actually founded Atlanta Plastic Surgery, the group that I'm a part of down here. And Dr. Hartram was a household name in plastic surgery. I knew his name when I was a medical student. And so he described the tram flap in the 80s, and then a few individuals throughout the country then turned that into a microsurgical operation and really took it to another level. One is Dr.
What does microsurgical mean?
That means completely. So in order to transfer a large piece of tissue, it needs to be transferred with a blood supply. So if I were to just try to amputate a large piece of skin and fat from the lower abdomen, and if I were to just cut that off and then sew to the chest wall, the tissue would die because there's no blood flow into the tissue or out of the tissue. So why Dr. Hartram's procedure was so revolutionary was that he would then while the tissue is still connected to the rectus abdominis muscle and connected to a blood supply, he would tunnel all that abdominal tissue up to the breast. So the blood supply never had to be disconnected. He could sort of tunnel all of that tissue up there. Very revolutionary, but the procedure had some downsides. You basically had to sacrifice the entire six-pack muscle of the abdominal wall. It had a few other downsides, which I won't go into, but it was a true keystone in terms of advancing breast reconstruction. And then in the 90s, Dr. Grotting in Alabama, Dr. Cerletti, these two really took this procedure to another level. And I will say, to Dr. Cerletti's credit, not only is he an incredible clinician, but he is still a very forward-thinking individual. So, fast forward into the 2000s when I was his trainee, he didn't just sort of sit back and say, well, I've made my contribution. He was always pushing the envelope. And so I started nerve grafting with him when I was in residency. And there were a couple other of my mentors at Penn who I have to give credit to. And so it was very exciting to come down here and to be able to offer this in an area that really this hadn't been done before. And in the Southeast in general, there are very few, if any, individuals that offer this. So I'm just a byproduct of an incredible mentor. And so I was telling everybody, I sort of hit the residency lottery by having, and I think Dr. Gray could speak to this. I could go on for an hour about everything Dr. Sletty's taught me in and outside of medicine. So
I feel the same way. I did my fellowship at Georgetown, and they wrote a lot of the textbooks on Reconstruction, Scott Spears,
yes.
Mohabedi, and so forth. So I kind of hit the lottery too, and I get what you're saying, having operated with Joe Cerletti. He's an incredible surgeon who really works with patients and educates them. He's compassionate, and he
Yes.
tries really hard to get all this information. This is the mark of a good surgeon, right? Is that you can take a patient who is in distress, who's still grappling with their diagnosis, but begin to help them see beyond the diagnosis to what life looks like afterwards. Because that's where we have to go with this. And these conversations need to be able to paint that picture for patients so that they can see it for themselves, so they can understand and give an informed consent about what's going to happen to them, you know?
Mhm.
And I think that all of the trainees of Dr. Serletti that I've worked with are able to do that same thing. So, Doc, I've got questions for you about, let's talk about people who have to get radiation after their mastectomies, right? Because, we know, and this is a show that's about Black breast cancer in particular, Black women may have more advanced disease. They may have node positive disease. They may need post-mastectomy radiation. Does that impact how the procedure, how the outcomes for you? And are you guys looking at that?
Absolutely. So it's interesting that you mentioned this. One of my research projects when I was a resident was looking at the outcomes related to immediate reconstruction. And for the audience, when we say immediate reconstruction, that means doing the IEP flap or doing the tissue transfer at the time of the mastectomy. And there are two schools of thought. And again, some of this ties back to Penn. Penn was very much a proponent of immediate reconstruction. So transferring the tissue at the time of the mastectomy. One of the other powerhouses in breast reconstruction and breast cancer care is MD Anderson. And historically, they advocated for a staged approach where we would place a tissue expander. And then if a patient required radiation, the radiation would then be performed. And subsequent to that, 3 to 6 months later, the DIP flap would then be performed with the thought that the tissue that you transfer is never exposed to radiation because there are some untoward effects related to that.
So can you not get this if you have implants?
The free tissue transfer, you
No,
can.
the resensation.
Oh, you absolutely can. You
Okay,
absolutely
okay,
can.
okay. Yes.
And I can. That's a little bit of a separate topic, but I can absolutely talk about that as well because that's.
I didn't
also,
mean to take you off track. It just
no, absolutely. So, what I will say, because of where I trained, I was very early on. I was dogmatic about immediate reconstruction. I did an outcome study, presented this paper all over, and I said, you know what, this is. But at some point, you need to sort of think for yourself and adjust your practice based on what you feel is right. And so I use both approaches in my practice. I use both immediate and this delayed immediate approach. And one way that I think about this issue is that if somebody has a lower abdominal tissue volume that is barely adequate, where it just barely gets them there in terms of restoring their breast volume, I am more likely to not do immediate reconstruction in that patient. Because if they're barely getting there in terms of breast volume and then they're radiated, which often causes volume loss, that's sort of the most common drawback to radiation. Now I'm really fighting an uphill battle. Conversely, if someone has, ample lower abdominal volume, and I could say to myself, all right, well, they can tolerate a little bit of volume loss, then I'm usually okay with them proceeding to immediate reconstruction and then radiation. And the last thing I'll say about that, which makes this whole decision-making process so challenging, and Dr. Gray could speak to this more intelligently than I can, is that for so many patients, the need for post-mastectomy radiation therapy is not known until after the mastectomy. So it makes this decision-making process very, very challenging at times.
It does. And I wonder if people who are watching understand that all of this is going on in the background, right? From the minute the breast surgeon refers this patient and you start talking about, what types of reconstructive options that one, the breast surgeon has introduced to that patient, but two, that they might be a candidate for. There may be reasons why the surgeon doesn't recommend certain things to you. And I hear patients say all the time, well, I was never offered this or I was never offered that. And I tell them every single patient, every cancer is different. Every reconstruction is different. And you can't always say, you can't always compare because there's a whole thought process that goes on that is really hard to convey. And so I think that listening to this part of the conversation, even though it seems maybe a little technical, it's super important for patients and advocates to know, like, there's a whole method for why and how it all happens. And you can even ask your surgeon if you have questions about it, or if you feel like your care is not equitable, because we know that historically Black and brown women have not always been offered reconstruction. They haven't always been offered the same standards and the same things. You can ask. And you can say, hey, listen, what are you thinking over there? I smell smoke. What's going on? Talk to me about my options a little bit more. And then that opens up an entire conversation with your surgeon.
Mhm. And I think that's so important. And one thing that I try to stress to my patients is that what you really want to have are options. There's no one way to solve the problem. And when it comes down to this decision also about immediate reconstruction or delayed immediate, if I'm sort of on the fence about what I think is best, I will certainly use sort of shared decision making and say, look, here are the pros and cons of this approach, here are the pros and cons of that approach. And one thing that is a little bit of a pet peeve of mine is when or a patient comes to see me a year after their mastectomy, and they'll say, well, I was only told that I could have this type of reconstruction or that type of reconstruction. I wasn't given all the options. And yes, sometimes patients can be fitting a very narrow profile of what's appropriate. But I would say for the most part, most patients have a vast array of options. And so it's, I think, more important than anything is to be able to choose a surgeon who can give you those options. And if they cannot offer a particular option, they need to be willing to say, okay, well, there's someone else who offers this. You may want to chat with them as well. And
I was just going to ask you that question. What happens in certain communities where there isn't a plastic surgeon?
There isn't, and
there
that
are
happens
women,
so often with
Yep.
Black women.
there are women who are watching right now who are facing this diagnosis and thinking about, well, I might want reconstruction, or I may want this. Is there a place where they can go and find surgeons who do this procedure?
Well, the resensation technique itself is, we often need to use an off-the-shelf product. It's basically a cadaveric or a processed nerve graft. And this is one of these times where the collaboration of industry with the community is incredibly helpful. So the company that sells the nerve grafts has a surgeon finder. So the company is Axogen, and it's AXOGEN, and they sort of offer this proprietary technology. And with that, they have a surgeon locator on their website, which allows you to search
great.
by zip code. And so it's
Get it like that. Interesting. We also know that a lot of Black women don't get reconstruction because they don't have a surgeon nearby, or they may not have the money, may not be covered by the insurance, which we know is not the case, but they don't think about that, and they don't have awareness of that. But also, we do know that there's a preference for the DIEP flap because they're more inclined to use their own tissue as opposed to bringing a foreign body into their body. So we often hear that, well, I'd rather have my stomach than have an implant that came from where, a company. So that's definitely something of preference. I think that, but I know that I had never heard of this, Dr. Michael. So, and I'm in the space every day. So, and I learned about it, once I met with you, I asked Mo about it, but we need to build the awareness of it because so many women, I'm sure, don't have knowledge of this. And especially when they're first diagnosed and they don't know anything about breast cancer, so we want to try to help educate and let people know that this is an option for them and to ask for it, which is a lot of times what Black women have to do with doctors, is ask for what they want because they're not offered necessarily.
And Ricky, it brings up a really good point. The question I'm asking Dr. Michael in the chat is, what about all the women who maybe are going back for an implant exchange 10 years later or some other time, who weren't offered resensation or who didn't know about it, or it really wasn't widely available at the time? Are they perhaps candidates for resensation? And so we can definitely talk about that too, some of the decision making and some of the criteria for that, if possible.
Absolutely. So the scenario where somebody's had a mastectomy, they weren't offered resensation, and then whether it's 6 months, 10 years later, they're now looking to undergo this procedure, it's quite variable. And I will say, again, we can offer resensation either with a DIEP flap, so using the tissue from the abdomen, or with implants. combining the DIAP flap with the resensation techniques is typically preferred in a delayed setting. And I'll spare you the technical details for that, but it comes down to sort of when we harvest the vessels, the intramammary vessels for the tissue transfer, we uncover some nerves there that are helpful in terms of sort of reconnecting the circuitry. Whereas in an implant exchange case, we're not really going underneath the rib. And again, there's some technical nuance to the whole thing, but usually in my opinion, it's more of an effective approach when it's a delayed DIP. For cases of if somebody simply wants, say, their implants exchanged and then a resensation procedure, I would say now we're starting to get a little bit more on the fringe, and everybody is coming from a very different sort of time frame with which they had their surgery and how the mastectomy was done and whether they had radiation. There's so many variables, but that starts to get to be a little bit more of a dicey situation where that would be very specific to a patient, and I would say we would have to really temper our expectations there.
Because I'm thinking, gosh, if I I'm 10 years out, but I think about other people that may, well, I'm 10 years out, I had implants, and now I have a belly because I'm older, right? Can you help me out? Can you give me can we do the D flap, right?
100%. Absolutely.
I'm seeing women, they're like, wait a minute, this sounds really good.
Those are good candidates because, like he said, you have to go. I say fish out. He said harvest, but you got to go find that blood vessel and dig around a little bit deeper where that nerve might live and have been cut. Because once you cut it, it kind of retracts and it goes back in, and it can be harder to do 10 years later. You know, you like pulling out an old splinter, right? If you got a splinter, it's better to take it out while it's still sticking out. But if it burrows, well, now we gotta do a lot more.
Yeah.
Right.
And that can be really hard after years of scar tissue, after radiation, after, just kind of life and shifting of things, and that capsule forms around that implant. So better to do it immediate, or if you are getting the autologous or getting your own tissue put in, because they got to go in that area anyway and pull out the vessels. But I think the other question that I have for you is about measuring sensation. We just got back from Vegas from Society of Breast Surgeons, and we had a number of posters. My good buddy Ann Pellet did one. How do we measure what somebody's sensation is? And do we measure before and after, or do we measure more after? And are there kind of some things that you look for to help us define what sensation is rather than I feel it?
That is a question with a long answer. I will say this, so I'll back up a little bit. So Dr. Gary mentioned Ann Pellet, and so when these techniques originated, they were really specific to nerve grafting using your own tissue. And Ann is a plastic surgeon in California who's dual trained as a breast surgeon as well, and her husband is a peripheral nerve surgeon. They operate together. And so they've really pioneered.
Lucky for them, right?
Utilizing, exactly. You think you had a tough day. So they've really pioneered the utilization of these techniques combined with implant-based breast reconstruction. And to go off on another little tangent, I had mentioned Dr. Hartramp, the founder of our group and a pioneer in breast surgery. When he started doing his initial form of reconstruction, people from all around the world would want to come every week and watch him operate. And he said, okay, well, we're going to just have everybody come one weekend a year. We'll have live surgery, we'll have talks and everything. And that turned into the Atlanta Breast Symposium. And our group puts that together with Emory. People come from all over the world. And it's one of those meetings that's on the calendar for a lot of plastic surgeons. And so one of the highlights of the meeting is the live surgery. And me being one of the sort of local hosts and an individual host planned the meeting. One of the surgeons that we invited this past year was Ann and her husband. And it was just such a pleasure to operate with them and to exchange ideas. And I will tell you, I used to be much more enthusiastic about nerve grafting with DIP surgery. And I would do some nerve grafting with implants, but I wasn't as enthusiastic about it. But after spending that day with Ann and her husband, I am just as energized to do it in either setting. And to circle back to the original question, I will say that Zeev, her husband, is a peripheral nerve surgeon. They've really done a much better job, I will say, of tracking their outcomes. And there are these PSSD, it's a special device that they use to sort of measure sensation. Other ways that this has been measured is a little bit more traditional. It's called a monofilament test, where it's something that basically looks like a thicker piece of fishing line, and it comes in different thicknesses, and you place it on the breast, and it can be an indicator of sensation. And so there are monofilament tests. There's this PSSD test. I will say, because our group is kind of sprawling, and I go to multiple offices around the Atlanta area, and we're just clinically very busy. I have a little bit more of a rudimentary test where I'll just kind of ask patients, how's the sensation? Or I'll take a cotton tip applicator and say, do you feel here? Do you feel here? But
Sure. That's what we do too. So I'm just curious to know, because
Yeah.
fortunate or not, I was in a motor vehicle accident when I was in college, and I have a skin graft here. So I can feel something touching, but I can't tell if it's hot or cold. I can't tell if it's sharp or smooth. And so the sensation is kind of blunted. So I use that comparison for patients to help them define it as well, because patient expectations, right? Have you had patients who maybe it wasn't what they expected or what they thought? I think that managing that, and then so Stephanie, let me pull you back in and ask, do you get little shooting pains and zingers and other kinds of interesting sensations as your healing continues?
Not anymore, but when kind of months after I did, it was like sharp pains, and sometimes it felt like Novocaine, when Novocaine wears off, that tingling that you feel. So it was some tingling or was some sharp pains. So I don't, we're 2.5 years out, and I don't get those sensations anymore, but for a while I did.
I get those. Should I get them? I do. Periodically.
Good. How do nerves regenerate? How slowly or how fast,
Yeah.
Dr. Michael, do the nerves regenerate for patients who, just have a lumpectomy even, or a mastectomy, and they're starting to feel some things? What's the going rate for nerves to sort of grow, if they're going to grow?
well, usually we sort of think in basically how much a nerve will grow for a specific time period. And one number you'll often see thrown out there is a millimeter a day. And the nerve gap that growing nerve is trying to overcome is very variable from one patient to another. And also the anatomy can be quite variable. So it really is very patient specific. The other thing that's very interesting, and why I'm so passionate about the nerve grafting, is that it's interesting to hear you say, Stephanie, that this is sort of settled out for you, and you generally are not having these sensations. Whereas Ricky, conversely, the nerve endings that were cut during your mastectomy, they were, and this is not a criticism, this is just a reflection of where things were 10 years ago. Those nerve endings were never addressed. So they're sort of raw nerve endings.
Hanging out.
And when you have a raw nerve ending, oftentimes it will form a little irritated stump on the end that we call a neuroma. And I suspect that a certain percentage of patients that have chronic pain or discomfort after their mastectomy, some would categorize this as post-mastectomy pain syndrome. A certain amount of this is sort of neuropathic pain from untreated nerve endings that weren't dealt with at the time of the mastectomy. And sometimes we can actually, even in delayed setting, I have some very nice photos of this I've given in talks, where I can go back and find a neuroma, resected nerve graft. But in an ideal world, you sort of prevent that from happening to begin with. And I think as we see more data in terms of resensation and nerve grafting techniques, we'll see two positive benefits. One is the resensation, which is, goes without saying. But I think what we will also see are lower rates of chronic pain. And if I could just make one more point, it's interesting, this whole concept of giving cut nerve endings somewhere to go and something to do. it's really taken hold in extremity amputation literature. So as you can imagine, patients that have a leg amputated, post-traumatic or otherwise, have a high rate of phantom pain, sort of chronic pain related to the amputation. Well, a mastectomy it's an amputation. Let's not confuse the two things. And
Yeah.
they have more similarities than they have differences. And so there are different techniques in the extremity literature where people have given these nerve endings somewhere to go and something to do. And these patients, there's very good prospective data on this, have dramatically lower rates of post-amputation pain.
Mm.
I love that you brought
Wow.
that up, the subject of post-mastectomy pain, because many patients will come with pain after mastectomy and maybe not be believed by their doctors, or it may not be addressed adequately in in the sort of, not in the post-op setting, but now you're 6 months out, you're 3, 6, 12 months, and you still have pain. The doctor's like, well, you shouldn't have any feeling at all. So why are you having this pain? And they don't quite know what to do with those patients. And it is because of those nerve endings. And so I think the first thing for people watching, if you have chronic pain after your mastectomy, one, your doctor should believe you.
Something's
Two,
wrong.
yeah, they should be looking for the points and the places. I know in our clinic, we've done injections and things, where you can at least try to find those points and inject Kenalog or steroids or, lidocaine or something to try to relieve some of that discomfort. And some of the pain docs do it too. But it's a really, it's something we don't talk about enough. So thank you for bringing that up, that, this is not only for resensation, but it can help to address those nerve endings.
Yes, very underreported.
Yeah.
And if you look at some of it's interesting. I recently went back and looked at some of the literature, even going back 10 years on post-mastectomy pain syndrome. And if we listen to what our pain colleagues are telling us, they're giving us the clues 10, 15 years ago and saying, hey, try to preserve some of these nerves or try to repair them. And I think we were a little slow to listen to what our pain colleagues were trying to tell us. And in some of these papers, it's very interesting. They spell it out very plainly. And I think it took us a little time to catch up to some of these principles.
Wow. Wow. This is like incredible news. Harper's barking, of course. So I'm still getting over the fact that this is so new to me and I'm in this space. How do we get this word out? How can we help you help more doctors? How common do you think it is with plastic surgeons? Are they getting it? And patients just don't know about it? Or like, what can we do to make more people know about this?
Well, I certainly think, Ricky, you just what you've built here is just so tremendous. And this is just such another example of your efforts, basically allowing so many patients to, basically, keep up to speed in terms of what's offered out there. And I just think it's incredible what you're doing. The other thing I will say is that hats off to Dr. Peled, and there are some folks like Ann and her husband who are causing, real ripples throughout both the plastic surgery world and the surgical oncology world, where I think 2 years from now, this will be much more prevalent. And I can tell you, even from when they did their live surgery in January, just talking to others, that has caused such a dramatic effect even in our world. And the fact that they're able to sort of, advocate for such a procedure in both the surgical oncology world and the plastic surgery world, I think it's incredibly powerful. So she's one of a few, key opinion leaders that I think are doing a tremendous job.
Ricky, I think for our part as advocates and as an organization, we can also start to look at registries and look at data that examines if there are the representation of Black women in this procedure, right? How many Black women are getting resensation, and are there trials even that look at that? And that's an area that we can certainly advocate and investigate further as well to make sure that things are equitable and that our viewers, not everybody is learning about and getting the opportunity to get this, because we see patients younger and younger who are opting for, bilateral surgery, who are opting for deeps, who are in Stephanie's shoes a few years ago, and
and
they're looking to you, and they're watching this, and they're going like, wow, I didn't even know this was possible, and look how amazing she looks. And she's talking about intimacy, and she's having, like, people don't talk about that stuff, Stephanie. So thank you for bringing
Yeah,
that to light, because some people think this is as good as it gets.
I know.
Yeah, and I'm glad to do it because, like I said, I did not even know that this was a thing. And even beyond intimacy, it was funny. A friend of mine went through breast cancer a year before I did, and she was telling me the story that she had got implants and she was in the swimming pool and her top came down. And like she didn't even notice. She didn't notice because she couldn't feel that her top was gone.
Hello,
so-
happens to me all the time.
Oh, yeah.
Happens to me all the time.
And so, it's intimacy, but it's also the small day-to-day things that you don't think about, how important the sensation is in your chest that affects your everyday life.
Yeah. It's funny because I used to never wear bras. My little fake boobs are bigger than the ones that tried to kill me. But so I never wore bras anyway, but I used to hate bras because they were so uncomfortable. Well, guess what? I can't feel that anymore. Bras are really comfortable to me now. I can't feel them. Right. So I know there's something going on here because I can't feel it. What I could feel before when I had breasts, so, but I think we have to just get this word out and we, let people know that this is something, there's so many things that you can't control when you have cancer and that you don't know is happening to you. So if there's something that we can help you control and have something that makes you feel better, the more, we have to make people know about it because this is a good thing to know about and to have happen for you. And especially for our young, when I talked to a baby breastie this morning, last couple, she had her mastectomy on Monday, and she knew nothing about this. I was talking about the show and I asked her about this, and she knew nothing about it. And 27 double mastectomy. She just chose to. She stayed 0, but she chose to get a double mastectomy at her age, and because she's afraid, and brave decision, but like something like this would make it a little more palatable, knowing that she could still have feeling.
Yeah, and just knowing that there will be life beyond,
Yes.
and you have
Exactly.
to consider your life beyond the moment of
Yeah.
surgeries and chemo. There will be life beyond that, and what do you want that to look like?
Right. Or feel
That
it.
that's a key point. We call that survivorship.
Mhm.
And you hear that term thrown around a lot. Oh, I have a survivorship clinic. Like we started one, and we started looking at sexual dysfunction,
Yeah.
for example. But it's like after your treatment is over, or even during, survivorship starts at diagnosis. I tell patients.
Yes. Oh, it does. The day you're
one.
diagnosed, you're a survivor. The day
Survivorship
you're
starts
diagnosed.
then. And all of the things that come along with it, all the stuff the doctor doesn't have time to talk to you about, or that you're still not even able to wrap your head around, that come beyond the diagnosis, that come after surgery, after those drains are out, right? After that first mammogram, like getting your life back, right? Getting your groove back.
Yeah.
All of those things are part of survivorship that we need to
Yeah.
rope in early to
Yeah.
give patients hope, because as soon as you hear the word cancer, your mind
Yeah.
goes, goes
To a
in a different
different
direction.
direction.
So you
Doesn't
guys
go-
are giving a lot of hope today. Absolutely.
Yeah. Yeah. Dr. Michael, how can people reach you? I'm putting your info in the chat.
Well, also I will say, if anybody wants to email me directly, please feel free to email me directly. My email is mmirzabegi, MMIRZABEIGI @atlplastic.com. I give all my patients my personal contact info, and I will say that if anybody has any questions, you can always reach out to me directly. And there's a lot of information, I think, that you can find through the Axogen website. Again, they've really created a great website, which
Mhm.
helps to inform patients. And there's also the surgeon locator on there. Yeah, please, anybody can, please feel free to reach out to me.
At ATL, what? ATL,
Plastic. Yeah,
at ATL Plastic?
yeah, .com. Yep. So,
Plastic with an S?
yes, ma'am. Yep. atlplastic.com.
Okay, cool.
That's huge. Thank you for providing that. I don't know if you do
Yeah.
any teleconsults or anything like that too, but I'm sure there's people all around that.
You're going to hear from our audience. Mm.
Yes.
Absolutely. The case I just came from that ran a little late, my patient was from Alabama. And so we did an initial telemedicine visit just through Zoom initially. And then there are several breast surgeons here that we work with, all fantastic. There's some very talented breast surgeons that I will normally sort of shunt patients to if they see me first. So she's just another example of somebody who we first connected through a telemedicine visit, and then subsequently she came to Atlanta and saw myself and Dr. Rylan Gore on the same day.
That's
And
my buddy. I know Rylan very well. What a
we were just
sweetheart.
together.
Love her.
She is a wonderful person and an outstanding breast surgeon.
Wow.
Absolutely outstanding. And
Tagging her in the chat.
Yeah. One thing I will say is that so much of the outcome is dependent on having a great breast surgeon, not just for the obvious reasons that you want someone who's kind, compassionate, capable, but the aesthetic outcome, the sort of the meticulous nature of someone like Dr. Gore in preserving the nerves that are able to be preserved, and what can't, then I'll try to repair. It's just such a collaborative effort. And so our case, going back to that, it was an implant case with resensation. And we started the case at the exact same time. It's not one of these times where, I'm just elsewhere and then I come in at the very end. It's collaborative. So it also helps to have someone who's as talented and easy to work with as Dr. Gore. So she's somebody that's on my speed dial. So if a patient sees me first, and I think, Mo, you could probably attest to the kind of person surgeon that Rylan is as well. So.
Yeah, absolutely phenomenal. And you're right, and patients should always know that you should get a second opinion, that you can be an informed consumer, even if you have cancer, especially if you have cancer. Like, it's not the time to just settle for whatever, and you have the right, and it's okay. Give yourself permission to shop around, to ask good questions, to bring someone with you, to do your due diligence, because this is the most important relationship you're going to have for a long, long time. It's not just a one and done, wham, bam.
It's many years. Yeah.
It's relationship. Yeah, absolutely. And I can't think of a better, you can tell by listening to Dr. Michael that the type of relationship you want to have with your plastic surgeon, you want to have with your breast surgeon. And so look for that, ask for that, expect that.
Demand it, expect it. Well, a second opinion saved my life. So I had to go take it in my own hands to find a doctor that could help me. So we thank you so much. We thank you so much. And we're going to write an article about this to put on blackdoctor.org. So, people, another way to reach people, they have an incredible, audience. We're so blessed to have this platform to work with them. And we'll get some more word out about this because it's so important for us to know and have a happy thing happen when you have breast cancer. What a concept.
Stephanie, are you doing more advocacy work? Are there places where people can follow you on any social media or anything like that? Or if they have questions?
Listen, I just signed up for Facebook like 5 months ago. So I'm on no social media. I don't post anything. So, I have done some articles, but outside of that, no.
So we'll funnel stuff to you through me. You guys know my email. It's up here on the screen. Email me and I'll get you to step.
Gotcha. Any last words or parting comments for people watching who are, they're in the middle of it right now? Stephanie, you got anything you want to say for those folks? And then Dr. Michael will hit you, and then we'll head on out of here.
Get a second opinion. I know you said that, but that was just so important. Having someone with you, because you can't think of all the questions that you want to ask when you're in the moment. And that Mirza Beggy was a wonderful plastic surgeon. I was like sad. He was like, well, you don't have to come back unless you realize like, oh, is our relationship over? I mean, that he was that wonderful that I was sad that our relationship is kind of over. So that's it. He's a great plastic surgeon, and it's been a success.
Great.
Well, I can't tell you how profoundly meaningful that is. And it's just to be able to be entrusted with an individual's care, and someone like Stephanie is just, it's so energizing too. And I think, well, you could probably attest to that as well. It's just when you are privileged to care for such extraordinary people, it will really energize your spirit. It's just, we're humans like anybody else, and we get down and we get frustrated. And again, it just is so reinvigorating, spiritually. So I thank you for your kind words. And I will say, it's also just, I wanted to thank you all again for the opportunity to be here. It's truly an honor. And if I could sort of leave some sort of parting statement, it would just be that I think everybody who's going through this is going through this for the first time. And sometimes patients can have this perception in clinic that, well, everybody's a veteran, everybody's gone through this, and now I'm overwhelmed, and it's so much going on. But it's important to remember everybody is going through this, for the first time.
Yeah.
And so you really, you want a team to take care of you and bring you from point A to point B effectively and compassionately. And there's no shortage of folks out there. There's a lot of talented surgeons and physicians out there. Whether we name them on tonight or not, there are so many wonderful and talented physicians out there. And it's just a matter of finding the right one and the right person for you. And again, there's so many incredible surgical oncologists and plastic surgeons who are passionate about breast reconstruction, breast cancer care, who can really take you from point A to point B and get you through the whole thing.
True. Find a specialist too. Where you go matters, and not to knock anybody's, expertise, but we train in this, we practice this, we study this, we do this every day. And I think it's really important to take that into consideration if you have the option, and not everybody does, but even your general surgeons, ask about how many of these procedures and how often do you do this, and kind of get a feel for their level of comfort, regarding mastectomies and lumpectomies, because it matters more and more. It's not just I'm going to take out this lump. There's more to it than that, and it should be more to it for you as a patient as well.
And if you have trouble and you want to need help finding a doctor, you can reach out to me. And, Dr. Michael, you're now in my family and my sandbox.
Love
So
it.
look for my emails, because I will be sending them, and I'm going to text them at 4 a.m. and ask questions. So I will help you, and I will, we can always find you somebody.
Absolutely.
Well, we hope this has been relatable and reliable and real. It's what we set out to do every single Wednesday night at 6 p.m. on blackdoctor.org. And we are so thankful for the opportunity, the platform, the sponsors, the love, the patients, the doctors. Thank you so much. We love it.
Thank you, Amgen. Thank you, Genentech. And thank you, guys.
The doctors
Love, Steph. Breasty love.
next Wednesday.
Breasty love. See you next week.
Heart.
See you next week. Bye. Thank you.